thank you again for your attention. It was good that we changed the order of the presentations, because I think this proportion kind of leads to hypoplastic left heart syndrome, although we wouldn't on the classic hypoplastic left heart syndrome use the term disproportion. But there is a little bit of confusion sometimes, as Dario pointed out, when the left ventricle looks squashed, the people sometimes think that they are dealing with a hypoplastic left heart syndrome. Now, typically, hypoplastic left heart syndrome involves the mitral and the aortic valves. And we have mitral atresia, or very severe stenosis, and this will lead to a small left ventricle. And at the same time, we have aortic atresia, or severe stenosis, which will lead to a small aorta and aortic arch. Now, I'm going to give you a little bit of clinical background and a little bit of the anatomy as well, in order to understand what hypoplastic left heart syndrome might mean, or how you might see that or suspect that on your ultrasound scanning mid-gestation. Now, because we have a problem with flow on the left side, there is inadequate flow into the ascending aorta, or there is no flow into the ascending aorta, and therefore flow to the aorta has to come in a retrograde fashion through the arterial duct, transverse aortic arch, and back into the ascending aorta. And we know it needs to go to the ascending aorta, even if we don't see that, because flow needs to go to the coronary arteries. Otherwise, the heart would not contract and the baby would not be alive. So this is a concept of what we call a duct-dependent systemic circulation, which I'll talk a little bit more in a second. Now, babies that have hypoplastic left heart syndrome postnatally, they will require what we call a Norwood procedure, and that's a 3-stage procedure. First few days of life, first 4 to 6 months for the second stage, and around 2 or 3 years of age, if they're still alive, they will have the 3rd stage. And this involves a combination of aortic arch reconstruction very early in life, but eventually it will lead to a univentricular repair, or that is one main pump, which will be to the aorta, a newly created aorta. So let's go back to the concept of a duct-dependent circulation. There are basically 2 types, and they both depend postnatally on the patency of the arterial duct, and prenatally as well, to maintain adequate flow. And that adequate flow to the lungs will create a group of conditions where there is duct-dependent pulmonary circulation. The baby will present mainly with cyanosis, and it can go off and collapse in a major way in the early neonatal period. And then there is a dependence for the blood to go to the body, it's a duct-dependent systemic circulation, and the presentation is quite different. The baby can again go off very quickly once the duct closes, or it starts to close significantly after birth, and presents mainly with acidosis. And we're not going to talk about the duct-dependent pulmonary circulation, but the duct-dependent systemic circulation. And that basically involves a group of conditions, the hallmark of which is aortic obstruction. So this is more or less the list: hypoplastic left heart syndrome, critical aortic stenosis, coarctation of the aorta, for which Dario has already said there is a high number of false positive cases, interrupted aortic arch, and anything that is very complicated that has an associated aortic coarctation. So it could be tricuspid atresia, doubling left ventricle, any complex heart, plus significant aortic obstruction will be a duct-dependent systemic circulation. They will all be managed more or less in a similar way, being aware of the high false positive rates for coarctation, which to start the baby on prostaglandin and early neonatal surgery or intervention, depending on the diagnosis. But of course, here we want to talk about hypoplastic left heart syndrome, and that's the aim of this talk. But I am going just to touch a little bit on critical aortic stenosis, because critical aortic stenosis can progress throughout the pregnancy, and the growth of the left ventricle be stopped, and therefore be stenosis early in the pregnancy and a hypoplast. So it can evolve to that. And coarctation of the aorta, I'm not going to talk because Dario has given a nice presentation on that, but it's not to confuse coarctation and not to diagnose that as hypoplastic left heart syndrome. Now, there is also another concept of a dependent circulation. This is important when we are assessing hypoplastic left heart syndrome, because that is not sufficient just to make the diagnosis of hypoplastic left heart. There are kind of prognostic factors that we have to assess to try and predict the risks that the baby will have at the time of the Norwood procedure. And the the foraminal valley dependent circulation will apply to a number of conditions. The most dramatic one is transposition of the great arteries, but it will affect cases where there is no outflow from the atria to the ventricle, so therefore atresia of either the mitral valve, which is what we are interested in, but also atresia of the tricuspid valve. So if there is a restrictive foraminal valley, that could have implications for this baby. Now, hypoplastic left heart syndrome, maybe you need the lights down a little bit because it's quite a light slide, this one. I think it's projecting well. So one of the classic hypoplastic left heart syndrome, and this is a specimen here, is a very, very diminutive ascending aorta. At term, the ascending aorta could be less than 2 millimeters, which is smaller than it would have been in a normal fetus at 20 weeks. So that great disparity in size of the ascending aorta, which then becomes larger as it goes towards the large duct, which is then feeding the descending aorta. But also you can see a huge right atrial appendage, a smaller left atrial appendage, and most of the ventricular mass is formed by the right ventricle. And the left ventricle, if present, is tucked away somewhere here behind the heart. But sometimes the ascending aorta can be a little bit bigger as well. And not only we have problem with the mitral valve and the aortic valve, but quite often there is an area of coarctation of the aorta as well. So it's really affecting all the structures in the left side. And of course, when we come to ultrasound, like most things that we see, there is always a spectrum. Not everything is absolutely the same in every patient. So we may have a hypoplastic left heart here with a small left ventricle. We have one that can actually, in terms of the physiology, reach the cardiac apex if we have problem with the outflow here and severe inadequate flow. So it's not quite the classical short left ventricle, but it could still end up having a Norwood procedure. And another type is when you have very thick wall ventricle with signs of brightness, usually reflecting endocardial fibrinostosis. So the size of the left ventricle can vary on B mode, but all of those cases will have an abnormal flow, and that probably highlights why introducing color may help diagnosing the subtle cases of hypoplastic left heart syndrome that could still be missed in mid-gestation. And coming back to the point that not all the time the image will be excellent, and no excuse here because my pictures are not as good as the German pictures, but I try to put pictures where are actually difficult because we don't always get just the beautiful pictures. But if you imagine this lady as having high BMI, and if you manage to get that, and you say, well, you can see 2 ventricles here, you could potentially, in a busy clinic say, what is it's okay. It's a difficult patient to scan. I managed to see the 4-chamber view. And that could pass, right and left. Maybe a little bit there you say that there is mild disproportion, maybe under the conditions, baby moving. So that could pass potentially as a normal scan at 20 weeks. And this is just a slight tilting of the transducer, and that comes the point again that don't always look at the picture from one particular angle. take a look from a side view or just move the transducer slightly, because this is the same fetus. And then as you move a little bit more, you can see that actually that ventricle here doesn't go all the way down. And if you look back, perhaps you just see here the right ventricle going around and forming the cardiac apex, which is one of the hallmarks of hypoplastic left heart syndrome. So it's more clear here, and sometimes increasing your contrast, narrowing the sector, you just manage to get better views, obviously suspicious of a hypoplastic left heart. And when you put the color, it would have been much easier in there. And in a difficult patient, color will help sometimes. You need to know how to use the frequency of the transducer for the color as well. But this is the same fetus on the same day, and you can see that there is flow through the right side of the valve, but not through the mitral valve. This is again another case. It's without color, and it's a magnified image, and it comes again to magnify your image, look back, stop, make sure that you see valves. We do have 2 valves here, but in real time, that valve open and that valve hardly open. But of course, when you put color, it's immediately apparent that that ventricle is a hypertensive ventricle. There was severe stenosis and no way out, so flow cannot get in because that ventricle is packed with blood at a very high pressure. So color very useful to diagnose cases which may be borderline at around 20 weeks and may be passed as normal if you don't use color. This is a scan image. And I'm just going to take you through now a few heart specimens just to give an idea as to why we have such a great variability. It's not a very good scanned image. It's very, very light, and I couldn't darken it. But it does make the point here to show the region. One of the commonest morphological reasons for hypoplastic left heart is what we call absent connection. So in here we have a small left atrium, the atrial septum, a big right atrium, the tricuspid valve, a big right ventricle, and what we call a slit-like left ventricle. So this may only be seen on a specimen when you cut through the myocardium, and you may find there's a small cavity there. So if there is no flow there at all, so you're not going to show that on your ultrasound image. And if you had the heart in your hands, and this area here really has no connection, that's why it's called absent connection. You could, where this arrow is, you could put your hand through there, like that, and lift up, and there's a wedge there. So you could separate the atrium and the ventricles and show here that there isn't anything there. And that area sometimes is clear on the ultrasound. It appears as a very bright, echo-dense area because there is some fatty tissue around here, the atrioventricular groove. So this is viewed from another view, which shows a muscular floor here between the atrium and the ventricle. The left ventricle is here, but no valve tissue whatsoever there. So it's just a blind end, as opposed to sometimes on the specimens, you can actually see there is a valve tissue, but the valve is imperforate. So it is more of an anatomical distinction here, but both cases being mitral atresia because there is no flow, and it's not really that relevant if there is no flow in terms of the prognosis and the diagnosis. But sometimes the valve that's there is patent, and it may have been bigger early in gestation, and as the pregnancy goes on, because it's an abnormal valve, it may not grow to the same extent. So therefore, up to the point when flow is going through that mitral valve, like a pater mitral valve, the ventricle grows up to a certain point of gestation. So it could grow quite well to 12 weeks and then stop in a way, or it could continue to grow up to 20 weeks. This heart here probably had that length at 20 weeks, maybe similar to some of the pictures I showed you when the left ventricle was just a bit short, and then it kind of stops because the mitral valve, although patent, doesn't allow too much flow to go through, because quite often you have aortic atresia. Now, this case is one, they can be missed in mid-gestation if the left ventricle has managed to grow sufficient to look relatively similar to the right ventricle, and it could then potentially stop its growth and end up as a hypoplastic or very borderline ventricle. But also, if this ventricle is very hypertensive, it will interfere with coronary artery perfusion. So those cases may have a worse prognosis postnatally, because you can have fistula malformations which are not always seen on ultrasound. So mitral stenosis and aortic atresia, it is an incremental risk factor for surgery. Now, ultrasound signs. So the way I decided to do here, I'm going to just list quite a few of them, and you have these on the lecture, so don't have to be writing all of them. A lot of them you know, some of them may be new to you. Then I'll try and demonstrate some of them in different types of hypoplastic left heart syndrome, and just pointing out some of the things that may be important to look at. So because we have a small or no mitral valve at all, the left atrium is smaller, and is smaller than the right atrium. The left ventricle is smaller than the right ventricle, if you can see the left ventricle at all. And this is kind of obvious because we're talking about hypoplastic left heart. So you're going to see only one valve opening. This is important because if you don't on your screening, if you only see valves, but if you don't see the movement, you can actually see the valve close and think there is a normal mitral valve when there is no movement. So only one valve movement. And a combination of these will give you a variable size left ventricle, and that's when it introduces problems for screening, because if the left ventricle is near normal size at 20 weeks or so, it could still be interpreted or misinterpreted as being a normal heart. Now, the left ventricular function is often impaired. With that degree of fibrinoelastosis, the ventricle is very hypertensive, there is impaired systolic function, and probably there is no diastolic function because there is no flow going into the ventricle. And the right ventricular function is usually okay. We eyeball that. It obviously is important that the right ventricle maintains good function because it's the only ventricle. So if that function is deteriorating, and then that baby is not going to survive very long, and it may be one of the reasons why babies will die spontaneously in utero, although spontaneous demise for hypoplastic left heart is not common in fetal life. But it will affect the long-term outcome for the baby, which is already quite guarded. Now, the foramen ovale as well may appear small during the scan. So all of those are details that need to be looked at when you're doing an assessment of hypoplastic left heart before doing the counseling. It's not sufficient just to say hypoplastic left heart. You may also have a dilated coronary sinus because similarly the left superior vena cava is a common association with hypoplastic left heart as it is with aortic coarctation, as it is with normal hearts. Yeah? With the screening as good as it is now, we see loads of babies that have a left SVC without disproportion. Can you not hear me? Sorry. Without disproportion and with a normal heart. So very common to have a left SVC. When we add color, we can have more signs that may not be apparent on the four-chamber view, but it may also confirm some of your suspicions from the four-chamber view. Obviously, if there is a blockage of flow from the left side through mitral and aortic valve, any flow coming into the left atrium from the lungs will have nowhere to go. So the flow is reversed across the atrial septum, i.e. left to right, and any flow that would have gone through the foramen ovale goes straight down the tricuspid valve, which is your systemic venous return and your umbilical venous return. Normally there is good flow through the tricuspid valve because if that's the only valve and if there is a problem with that valve as well, babies don't usually survive and they may succumb very early in the pregnancy. So if they are alive by the 12-week or the 20-week scan, the tricuspid valve has to cope with receiving the whole of the combined cardiac output. And across the mitral valve, you have no or very little flow. And this could be on a tiny ventricle, it could be on a ventricle that looks near normal size. And you also have to try and assess if there is any tricuspid regurgitation, because that will impact on prognosis following surgery. In my experience, that's not usually a big issue prenatally. You may have a degree of tricuspid regurgitation, as you have in normal hearts as well. Very rarely it becomes a big issue prenatally. Now, if you put color, and you see that color going through the pulmonary veins, because again there is a problem of blockage of flow within the left heart, the flow coming from the pulmonary veins can't get to the left atrium, so you have a kind of to and fro with reverse flow in the pulmonary veins as well, which may become apparent on the color flow mapping. And because there is a blockage in the mitral valve, not infrequently there are abnormal pulmonary venous drainage. So the blood is trying to get there, and then some of the embryological channels open up, something called a cardinal vein, or sometimes there is a true abnormal pulmonary venous drainage, so the flow goes away from the left atrium and into usually the superior vena cava. It's uncommon to see coronary artery fistula on the ultrasound, although that's more described on pathological specimens. And as I said, in cases of mitral stenosis and aortic atresia, that may become a problem which may impact on surgical outcome. Now, when you come to the outflow tract and the other vessel views, the 3-vessel and 3-vessel trachea view, the ascending aorta is often of very difficult visualization. As I said, some hypoplastic left heart aorta measures just about 2 millimeters at birth. So this will be a millimeter or less potentially at 20 weeks. But it can be seen if you look for it. If you have a hypoplastic left heart, we do try and image the ascending aorta the best we can, because that is one way of again adding risk factors for surgery. The smaller the aorta, the worse the prognosis, according to some surgeons. Some surgeons would say it doesn't matter, they'll do a good job, but I don't think that is quite correct. In contrast to that, we have a large main pulmonary artery and a large ductal arch, and this is going to lead to an abnormal 3-vessel view, when often you only see 2 vessels, which are the superior vena cava and the pulmonary artery, and the vessel in the middle, sandwiched between them, is small and may or may not be seen depending on the size and the quality of the scan. And you're going to have an abnormal color, particularly when you come up a little bit higher to your 3-vessel trachea view, when you're expecting to see the transverse aortic arch, because, as we said, this is a duct-dependent systemic circulation, and in case of hypoplastic left heart, that is one thing that will confirm the diagnosis, having reverse flow through the transverse arch. Just remember that not all flow reversal in the transverse arch equates to hypoplastic left heart, but if you have hypoplastic left heart, you have reverse flow in the transverse arch. And of course, down to the ascending aorta. So I'm just going to show a few pictures now to try and give you an idea of a spectrum and things that sometimes, if we don't look for them, may give patients a better prognosis than they may have. So we're going to start with an absent left connection. So remember that specimen, there is no communication here. If we could put our hands here between the left atrium, which is here, and the left ventricle, which we can't see, there isn't anything here. There isn't any tissue. So we have, it's better seen here when it's plain. We have here a dilated coronary sinus. The atrial septum is actually in here. Or maybe it is a venous, sometimes you see venous veins from the IVC coming here. It's probably a venous vein from the IVC. So one opening valve, good function of the right ventricle. We can't judge regurgitation here because we don't have color flow in this clip. So I don't think anyone would miss a case of absent connection if you get a good view of the ventricle. But potentially, if you're in a difficult patient, you can see here there is a papillary muscle right in the middle. And if you're not looking for flow, and if you're not looking, you could kind of fool yourself. You can see 2 ventricles if you don't slow down the image, because this is a big apical papillary muscle in a very dilated right ventricle. So you could, if you're not very careful with screening, even a case like this, which is very clearly one single valve, you could stop and print an image and say, but I can see two ventricles of equal size. That's the same clip on the same baby, and it becomes even more clear that there is only one inflow here from the right atrium. And once we do this, we can see actually that what I thought perhaps may be an atrial septum there isn't, because this is all right atrium. And actually this case was initially seen elsewhere and was giving a good prognosis, as good prognosis you can give for hypoplastic left heart, with a mortality of about 20%. This case turned out to be a very dilated coronary sinus, and you just see the pulmonary veins coming here perhaps. There's a little bit of flesh there, a little bit of flesh here, can you see? There's a little bit of reverse flow here in the pulmonary veins. This clip is not to show the pulmonary veins, but you can already see reverse of flow in the pulmonary veins. Yeah, a little bit of flash of blue here. So if you start seeing that, and then you should really look very carefully, because these pulmonary veins were not draining into the left atrium. They found a way and were going elsewhere with obstruction to the flow. So this again is a poor prognosis for this baby, and this baby actually died very shortly after birth with pulmonary edema. So those are the details that need to be paid attention if you're going to do the counseling. Now, if this is the same case, if we're going up from that 4-chamber view, showing a big right ventricle into the right ventricular outflow tract, that's our pulmonary valve coming here, a big pulmonary arch. We see here 3 vessels because there was a left superior vena cava and a right superior vena cava, as we've seen that dilated coronary sinus. So lots of flow, forward flow through the ductal arch. We just passed the bifurcation of the pulmonary arch, and as you come up to the 3-vessel trachea view, you see that there is a transverse aortic arch here with reverse flow just to the left of the trachea. So this confirms that this baby does have hypoplastic left heart syndrome. So the mitral atresia in itself does not mean hypoplastic left heart syndrome, because some cases that have that mitral atresia may actually have the aorta and the pulmonary artery both coming off the right ventricle. So if you don't have the aortic atresia as well as the mitral atresia, it's not hypoplastic left heart syndrome. So in this case, you have to have the full spectrum, aortic and mitral valve involved, and reverse flow in the transverse aortic arch. If you haven't got that, it's not hypoplastic left heart syndrome. It may be mitral atresia, but it's not hypoplastic. Now, this is a sagittal view, and as I said, the case of hypoplastic left heart quite often have coarctation of the aorta, and although Dario is showing you a beautiful image of 3D and B flow, we can actually, on 2D, if you use particularly power Doppler, you can get similar pictures of the aortic coarctation shelf here. This is on normal color, but if you put a power image here, it's even, you can get more persistence on that. So this is a case where you have a very large ductal arch, it's the same case, and the reverse flow here through the distal aortic arch. So that's your pulmonary valve, your ductal arch as you expect, and reverse flow through the distal aortic arch. And then if you look very carefully, you can actually see the aorta on the background, which I think is shown better on this image. So if you want to see that ascending aorta, and we do have to image that because it is one way of prognosticating for the Norwood procedure, this is where you would expect to see the aorta, and this is where you see the aorta, but you can see here is a minute vessel. This is, I can't remember the measurement, this can't be, this is about a centimeter here, so this is only just about a millimeter or less in mid-gestation, 24, 25 weeks. So this is a typical picture. Your ascending aorta is coming here, and it's just there. It joins the descending aorta. So ascending aorta here. So it joins the transverse aortic arch distally. And if you look on the color here, there it joins the transverse arch. There is your area of coarctation associated with the hypoplast, and you can see that shelf we're using. This one is called E-flow, which is a high definition flow. You can see that on power Doppler as well, and sometimes on the usual normal color flow mapping as well. Now, this is a different case where we had a left ventricle that looks like one of the specimens I'd shown you. Again, that image at this gestation looks highly abnormal. If this was seen 5 weeks earlier, maybe that difference between the left ventricle and the right ventricle wouldn't have been so great, and you still have an abnormal contractility. You would still probably have more echogenicity. So there are lots of signs to tell. It's not just the size of the ventricle. We know the mitral valve is patent because you can just see a tiny little bit of flow here that managed to go through that patent valve, but insignificant compared to the tricuspid valve. Does it matter? Not really in terms of surgical procedure, but it does add risk factors because they are more likely to have coronary, left ventricle to coronary artery communication, fistulous communications, which may affect coronary perfusion, and if it does, it could then impair the function of the right ventricle, which is the only ventricle. So there we are. In this case, we can see not only forward flow through the tricuspid valve, but you see also there is relatively mild to moderate at the most, tricuspid regurgitation, which comes and goes sometimes. It doesn't always stay there to the end of pregnancy. Sometimes once the baby is born and the pulmonary vascular resistance falls, it goes down, although it doesn't matter too much because that's going to become the systemic ventricle after birth. So it can sometimes be a problem, and you keep watching that, and it's one of the things we would have to monitor during the pregnancy to see if that affects the function of the right ventricle. So contractility is impaired, the size is there, it doesn't actually contract at all, doesn't change its size. It's very bright, probably reflecting areas of endocardial fibrinostosis. If you look at the atrial septum, it's quite thick compared to a normal heart, but you see here on the color there is still a little bit of left to right shunt, and then you would have to do studies in the pulmonary veins to try and ascertain the degree of restriction of atrial septum. One of the things is if that left atrium is very hypertensive because there is no way out through the mitral valve and there is restriction across the atrial septum, those pulmonary veins can start becoming dilated, muscularized, and that again adds to the incremental risk factor for the time of the eventual third stage of the Norwood procedure. So there are worse cases when the atrial septum is intact for the medium term. Now, this is a different case where there is no, it's the same case. We're going to look at the vessels. So we're starting from that small ventricle and the big right ventricle flows through the aortic arch. And the aorta here, although there is no forward flow, is a little bit bigger. You see here reverse flow through the transverse arch, and you can see the 2D image of the transverse aortic arch, which we couldn't see on the other case. So the size does vary. The bigger it is, obviously the more room the surgeon will have to do the aortic arch reconstruction, and there is a little bit better survival rates there. Now, that's probably give you quite a good spectrum of things that you can see in hypoplastic left heart syndrome. So atrial septum, you need to look, pulmonary veins, I'll come back to that. Size of the ventricle, just to, so you don't miss the case in mid-gestation. They may have a relatively good size or apparently good size left ventricle. But there are cases where will be hypoplastic left heart syndrome at birth, and it's very well documented, this paper from quite a while ago now, because there is a potential for in utero development or progression of severity of hypoplastic or left heart obstruction and hypoplasia leading to hypoplastic left heart syndrome. So this is such a case. This lady presented about 22 weeks with a very, very big left ventricle. Actually so big it was squashing the right ventricle, and I thought the baby potentially could develop hydrops, but it didn't. If we play that image, we see that that ventricle doesn't contract at all. You see reversal flow from left atrium to right atrium. There isn't, under normal velocity, there isn't much going through the left ventricle. If you decrease the velocity, maybe we see a little bit of blood swarming around there, really ineffective. No effective inward flow, no effective forward flow, although there was aortic stenosis. And this case was a classical hypoplastic left heart syndrome, because that ventricle, which had grown and was dilated up to about 20-21 weeks, remained of the same size, and the rest of the heart grew, so that the right ventricle was the dominant one at birth. Now, this is also quite an old publication now, looking at the pattern of the pulmonary venous drainage in hypoplastic left heart syndrome, because it will reflect the degree of obstruction for pulmonary venous flow to come into the left heart. And this is one slightly abnormal, but clearly abnormal venous pattern across the pulmonary vein. The signal in the pulmonary vein is a little bit similar, and you're probably used to that, to the ductus venosus of lower velocities, with an S wave and a D wave, but the A wave is much lower. It's usually positive, but occasionally you can get a bit of reverse flow in the pulmonary veins, but not of high velocity. This one here reads about 14-15 centimeters per second, and that's a high velocity for a reversed flow during atrial systole. And this paper basically, I think, was the first one that highlighted the importance of looking at the pulmonary veins in hypoplastic left heart syndrome, because the higher the velocity across the atrial systole in the pulmonary veins, reverse flow, the more significant the obstruction at atrial septal level as well as mitral valve level. This is a case that I've seen last week, I think it was, where we have mitral atresia with left atrium small here, the atrial septum is there, big right atrium. The atrial septum sometimes is difficult to judge because you're parallel to the ultrasound beam here. The left atrium itself is very small, so it's very useful to have that to see is there any obstruction or potential obstruction at atrial level. And that pattern, although not entirely normal, doesn't show from the right pulmonary vein any reverse flow, but it shows an increase in the S wave, quite a prominent S wave compared to the D wave, and no reversal flow in the pulmonary vein. But if we look at the left pulmonary vein, the same fetus, there was a little bit of reverse flow. So there was a degree of restriction, perhaps increased left atrial pressure, but not a bad prognostic sign at this stage. But it's something we have to monitor as well throughout the pregnancy, because sometimes these babies may need an early septostomy or make the atrial septum bigger surgically shortly after birth. Doesn't happen very often, but it will have an effect on the surgical outcome. This is another case from about 2 years ago, when you see here the mitral atresia, a small left atrium, a very thick atrial septum. That atrial septum was virtually intact. There was a tiny little flow here, a hole with flow left to right. It's a big right side. And if you look here, the pulmonary veins as well were very dilated. And if we look even on color, you can see that there is flow reversed in the pulmonary vein. It should be coming towards the left atrium and it's going back. And you have this classical to and fro pattern, which means significant restriction of flow at atrial level and is not a good prognostic factor. This lady, as I said, you can have channels that open up. The flow couldn't get into the left atrium. The drainage was normal anatomically, but there was no way out. So we had lots of channels dilated here within the atrium, the lung parenchyma, and eventually there was a channel, very tortuous channel, that joined the superior vena cava, and it was obstructed as well. We had this very abnormal, high velocity venous waveform in the channels coming up from the ventricles, from the atria towards the superior vena cava. So this was a poor prognostic factor. This baby, it was a conservative management postnatally, and the baby succumbed within the first few days, as expected in all cases of hypoplastic, anyway, if you don't operate on them. Now, we say all of that, but in reality, it is one of the most difficult lesions to treat. It's a big operation. The first stage, Norwood, is about an 8-hour procedure with a mortality that is very difficult to predict entirely in the first scan, because things can still change throughout the pregnancy. I'm not going to talk about that. Thank you. I think Rabi was just telling me to finish off.